This video illustrates the use of the Mako robotic arm to perform a reverse shoulder arthroplasty using the Stryker Perform system. It is the case of a 71-year-old female with a failed irreparable right rotator cuff tear. The first step is to import the patient's CT scan into Blueprint and proceed with planning as usual. Once the surgeon is happy with component position and implant size selection, the use of a Mako robotic arm is requested. Glenoid exposure requires adequate removal of all the soft tissue at the periphery of the glenoid in order to facilitate registration and bone preparation. It is particularly important to expose the inferior and the anterior aspect of the glenoid neck. A Hohmann retractor has been placed at the tip of the coracoid, and all the tissue that is present in the inferior aspect of the base of the coracoid should be completely excised in order to place the so-called checkpoint. The screen of the Mako robotic system will then show the two next steps. Step number 1, placement of a checkpoint, which is typically recommended to be inserted at the base of the coracoid, although it can also be inserted in other locations. And step number 2 will be insertion of the coracoid array. The coracoid array for Mako doesn't need the use of screws or pins. It has a jaw with sharp teeth that can be used to secure the array to the coracoid. It is important to tilt the array away from the patient's head so that the camera of the Mako robotic system will be able to obtain an unobstructed view of the array. The joints of the array allow careful placement of the array in the best configuration so that there is unobstructed view by the camera, and this can be confirmed by having your Mako shoulder specialist or Stryker rep move the camera so that it can be confirmed that there is adequate position of the array. It's important to be extremely careful when placing retractors so that retractor placement doesn't modify the array. This screen shows how we have an ideal position of the array where the two blue dots show centering of the array in the surgical field. Then the checkpoint is identified twice, and the second time it confirms that it's in the right location. Registration starts with selection of a few points in specific landmarks, including the tip of the coracoid, the superior aspect of the glenoid, the anterior aspect of the glenoid, the inferior aspect of the glenoid, the posterior aspect of the glenoid, and the center. Next, zone registration occurs by selecting a group of 3 or 4 points in a single region. The surgeon is holding the probe for registration, which is pretty sharp, so that it can pierce through cartilage or soft tissue, and with a pedal, it is very time efficient to select 3 or 4 points in the different regions. It can be more challenging to register at the base of the coracoid, tip of the coracoid, anterior glenoid neck, and superior glenoid neck. At the base of the coracoid, one can use the probe to trace 4 points around the checkpoint. At the body of the coracoid, it is possible to select 4 points by placing the probe around the clamp. And finally, at the tip of the coracoid, it is possible to simply pierce through the origin of the conjoint tendon, and provided that the probe is on bone, it will register appropriately. In order to register the anterior and inferior aspect of the glenoid neck, it is necessary to achieve adequate dissection of the soft tissues in these locations and use of a retractor that will completely expose the anterior and inferior aspect of the neck. The final step of the registration is the selection of 4 points along the inferior aspect of the glenoid. Next, registration is confirmed to be accurate by placing the probe into the blue spheres that will change in color from blue to green when the registration is satisfactory. That means that the surgeon can now proceed with registration of the Mako robotic arm. At this point, the screen of the Mako robotic system will ask the surgeon to confirm that there is nothing attached to the MISC, and then the Mako shoulder specialist or a Stryker representative will move the robot arm so that it's within reach of the glenoid. This is achieved by moving the robot until on the screen the representation of the robot falls inside a blue circle that is at an ideal distance from the patient's shoulder. This may require navigating the robot in and out several times, and if the operating room bed is either too high or too low, an indicator will advise the surgeon to either lower the patient's bed, like in this example, or get it higher. Next, an array is attached to the robot, and the screen will request the surgeon to move the handle of the robot so that it will go through different spheres on a cube. Every time the robot is advanced to a green sphere, the surgeon will let go of the array, and the robot will compute and make sure that the adequate position of the robot in space is estimated. It just takes a few seconds for the surgeon to go through all the different blue spheres of this cube, let go of the handle, allow them to turn to green, and then finish the robot registration. Next, it is time to confirm that the effector end is also properly registered by placing the array at the tip of the instrument. The preparation of the glenoid is performed with a high-speed burr. This burr is typically already mounted by the certified surgical assistant into an attachment that is placed in the MISC. And one more time, the location of the checkpoint is confirmed by simply placing the probe into the location of the checkpoint. And next, the accuracy of placement of the burr into the Mako robotic system is done by verifying the position of the cutting accessory using the same array that was used for robot registration. Then it is time to prepare the bone. The screen on the Mako system will color in blue the bone to be removed, and even though initially many surgeons start by mostly looking at the patient's bony anatomy, over time most people transition to doing the cut mostly looking at the screen and eliminating all the blue colored bone. It is important to realize that if a few specks of blue are left behind, it doesn't really affect dramatically implant placement, and if the surgeon goes slightly too deep, the color will turn into yellow, which again indicates some depth of the cut but doesn't really affect the preparation, as you can see on this image. Next, the software is advanced to prepare for the boss. And boss preparation is also done with the same cutting tool, with the idea of using rotational motion by the surgeon on the effector end to create that cone of bone preparation that will allocate the trabecular metal post of the base of the component. It's important to make sure that the entry point is perfectly prepared, as seen on this part of the video. If the surgeon is going to use a post, the same burr can be used to deepen that orifice that was created with the burr. But if the preference is to use a central screw, then the tool is changed to a router that will then be simply advanced in a single plunge maneuver and will automatically stop as soon as the desired distance has been achieved. A final portion before the robotic arm is removed is to confirm adequate rotation of the anticipated base plate, which is done by using the probe to identify the preferred location of the hole that aligns with the wedge if one uses a wedge system, marking that location with electrocautery and then removing both the array and, very importantly, the checkpoint, which is a very small metallic device that can be easily forgotten inside the patient's shoulder if one doesn't remember to remove it. The rest of the implantation is performed with standard techniques by driving the glenoid base plate into the glenoid vault and securing it with multiple favorite screws and placing a glenosphere once adequate primary stability has been achieved. One of the most satisfactory elements of using the Mako robotic arm for preparation of the reverse baseplate is that the surgeon can anticipate the position of the baseplate on X-rays in terms of version, inclination, rotation, and depth of insertion. And hopefully one day we can prove that improved component position translates into better patient-reported outcomes and decreased complication rates. Thank you very much for watching.